In our last sketch, we made the aorta dilated and get all aneurysmy. So dilated, in fact, that it ruptured. In this sketch, we're going to talk about an equally scary acute aortic syndrome, dissection. While rupture involves a full-thickness tear in the aorta, allowing blood to spill into the thoracic or abdominal cavity, dissection acts a bit differently. This time, only the intima develops a tear. Blood then surges into the vessel wall, right into the smooth muscle media layer that lies underneath. In effect, blood leaves one pressurized compartment, the cardiovascular system, and enters another, contained inside the vessel wall. It's kind of like a break in the hull of a submarine, which allows water to fill the damaged compartment until the pressure inside is the same as the pressure outside. Let this crack in the hatch symbolize a break in the intima. See how the inside of the compartment is lined with smooth muscle tile? This represents the media layer inside the vessel wall. This is the compartment that will be filling with blood. Acute aortic dissections typically occur in men greater than 60 years of age with a history of hypertension. In fact, hypertension is by far the most important predisposing factor, found in about 70% of cases. And it doesn't have to be chronic hypertension. Abrupt transient elevations in blood pressure can be enough to send that aorta over the edge. I'm talking transient hypertension caused by cocaine use, weightlifting, and even energy drinks. Man, I do 2 out of 3 of those things like every day, at the same time even. Imagine if I also drink energy drinks. If a young patient presents with a dissection, start thinking of the heritable connective tissue disorders, such as Marfan and Ehlers-Danlos syndrome. See those loose screws? That's Ehlers-Danlos syndrome, a group of rare disorders affecting the production of collagen, most commonly type 3, hence the 3 gill markings on that collagenous shark. Type 3 collagen is an important structural component of vessel walls, and when it's defective, arterial dissection and full-on rupture can follow. And you remember Marfan the Martian from our last sketch on aortic aneurysm? In its most common form, Marfan syndrome is caused by a mutation in the fibrillin gene, an important component of elastic tissue. Around 75% of patients with Marfan syndrome will develop dilation of the aorta, usually involving the ascending thoracic aorta or the aortic root. Watch out, because if this remains undetected or untreated, there is a high likelihood of aortic dissection. Another less common cause of dissection is iatrogenic damage to the aorta during cardiac catheterization. Oops. In addition, pre-existing aortic aneurysm, due to all those conditions we discussed in the last sketch, is yet another risk factor for aortic dissection. Just look at that thing. It's only a matter of time. Once a tear develops in the intima of the aortic wall, high-pressure blood jets through the tear and into the smooth muscle of the media, separating the intima from the surrounding media and adventitia. Most commonly, blood separates the middle and outer third of the medial layer, although it can occur in any plane. See the separation in the wall of the tube? It looks like an aneurysm, but it's just the wall expanding. That's called a false aneurysm. And the newly created space in the vessel wall is called a false lumen. Why is it so easy for the dissecting blood to push through that smooth muscle media layer like that? Well, it's thought that the media is already weakened by that same process we discussed in our aneurysm video, cystic medial degeneration. For all the details about the development and progression of cystic medial degeneration, check out our aneurysm video. For now, just remember that the vessel wall is weakened over time, due to a whole range of factors, including hypertension, age, smoking, and genetic predisposition. So as the water spreads across the floor, notice the smooth muscle tile up above is already previously damaged, and the high-pressure fluid just spreads on through. While it's possible to have an acute dissection of the abdominal aorta, it's pretty rare. The overwhelming majority of aortic dissections occur in the thoracic aorta, which is why we've recreated the thoracic aorta on the floor here, with this huge red pipe representing the aortic arch. It turns out that up to 30% of dissections occur at the takeoff of the left subclavian artery specifically, an area of high hemodynamic stress. So that third branch, that's the left subclavian about to burst. Aortic dissections are classified based on their location by either the Stanford or DeBakey classification systems. The Stanford system is more widely used, but we'll include both because you'll inevitably encounter some old crusty surgeon who wants you to know the DeBakey system. In the Stanford system, which is less complicated, There are two types of dissections. Type A, which involves the ascending aorta, and Type B, which affect the descending aorta only. Type A dissections account for 2/3 of all dissections. What if the dissection includes both the ascending and descending aorta? The Stanford system puts this in the Type A category because it involves the ascending aorta. The DeBakey system, on the other hand, is a bit more precise, consisting of 3 types. Type 1 involves both the ascending and descending aorta. Type 2 affects the ascending aorta only, and, not surprisingly, Type 3 affects the descending aorta distal to the takeoff of the left subclavian artery. So what do these patients look like? The classic clinical scenario involves a 60-year-old man coming to the ED with acute onset of severe tearing chest pain that radiates to the back between the shoulder blades. The exact location of the pain depends on the type of dissection, as ascending aortic dissections tend to present with anterior chest pain, while descending aortic dissections may present with posterior chest or back pain. As the dissection extends, the pain may extend with it. On physical exam, aortic dissection classically presents with significantly different blood pressures, sometimes greater than 20 millimeters of mercury between the arms, with the right arm having lower blood pressure than the left. This happens when the dissection has compromised the brachiocephalic trunk, supplying blood to the right arm, but has not yet extended to the left subclavian artery, which supplies blood to the left arm. Hooray anatomy! By the same mechanism, occlusion of the carotid arteries will cause decreased blood flow to the brain, leading to syncope. That sinking syncope feeling is embodied by this alarm, alerting the crew that they're losing buoyancy. Notice that we've placed it next to that rising carotid pipe. Let's also draw in a sailor showing off a recurring symbol for stroke, a stroke of black across the head. When aortic dissection reaches the carotids, expect to see some focal neurological deficits and even ischemic stroke. Rarely, aortic dissection can spread all the way down the abdominal aorta and obstruct the iliac arteries, which can manifest as pulselessness in the lower extremities. In reality, any artery that branches off the aorta may be compromised, leading to symptoms of organ ischemia. This can include paraplegia from occlusion of the vertebral arteries, severe abdominal pain from blockage of the mesenteric vessels, or renal failure as the dissection extends into the renal arteries. Dissection can even start working its way backwards towards the heart. Remember that the coronary vessels take off from the proximal aorta, so if the dissection spreads and compromises the coronary ostia, it can cause massive cardiac ischemia and MI. MI, of course, is represented by the broken heartstring, as usual. Though this is no time for revelry and skylarking and other tomfoolery. Back to your station. Moving further proximal, we reach the aortic valve, which is seated right at the root of the aorta. If the dissection hits that aortic root, it can actually pull that valve annulus wide open, causing acute aortic regurg. Just look at this guy over here, who's resigned to the fact that he's going down with the ship. All that regurg. Acute aortic regurg comes with a new onset diastolic murmur, so if you hear one in conjunction with classic symptoms of aortic dissection, it probably means that the dissection is heading towards that aortic valve annulus. When severe, acute aortic insufficiency compromises the systolic function of the heart, leading to heart failure and cardiogenic shock. That's not all, though. If the dissection ruptures near the pericardium, the pericardial space can fill with blood, resulting in cardiac tamponade. See that sailor there, grabbing that heart-shaped rag? Pressure on all sides of the heart gives us yet another reason for systolic failure and cardiogenic shock. Man, all those causes of cardiogenic shock. We've got coronary occlusion, acute regurg, tamponade. Might as well just put a big shock symbol right on the heart there. Hypovolemic shock is another feared outcome. Hypotension and shock can develop when all that blood leaves the systemic circulation to go hang out in the new false lumen that's being created. Let's zoom out a bit and go over all the causes of death we've encountered so far. You've got all those cardiac complications. Hit the carotids and you might cause a stroke. Various organ failures are symbolized on the right there, as the dissection pinches off various arteries. And in the bottom corner, hypovolemic shock. In case it's not super apparent that aortic dissection sucks, I have one more cause of death to mention. One of the most common, in fact, and that's rupture. Just like what we saw in our aneurysm video, a weakened vessel wall is prone to rupture, leading to hypovolemic shock and death. Well, this sketch got depressing. So let's see what we can do to prevent all this badness. Prompt diagnosis is critical if you want to even have a shot at saving a patient with acute aortic dissection. Most patients walking into an ER complaining of chest pain will get a chest x-ray. So we've drawn in our recurring skull and X bones flag. In aortic dissection, the classic finding on x-ray is that characteristic widening of the mediastinum caused by aortic dilation. Kind of like this whitened sailor scarf thing in the center of his chest. Remember, that's a false aneurysm that you're looking at back there, meaning that not all the layers of the vessel wall are dilating, though it's impossible to tell just on the x-ray. That widening represents the expansion of that false lumen. In stable patients, CT angiography is the gold standard for diagnosis of aortic dissection, which will show both true and false lumens as well as the extent of spread. So we've finally revealed the cause of this whole disaster. It's our recurring CAT scan CAD, who seems to have gotten himself caught in that false lumen. The typical appearance of aortic dissection on CT angiography is a widened aorta filled with contrast but divided by a dark band of tissue, which is actually the dissected intimal layers of the aorta separating the true and false lumen. Once diagnosed, time is of the essence. Treatment of acute aortic dissection starts first with strict blood pressure control to prevent further spread of the dissection. Following stabilization, treatment depends on the location and the extent of the dissection. Type A dissections are surgical emergencies because of the cardiac complications we talked about earlier. Stable type B dissections, however, are often treated with medication and close surveillance. Surgical intervention in type B dissection is sometimes necessary, however, especially if it involves the aortic branches, if it starts to spread, or if hypertension persists. And that's it. Let's see how much damage we've done here. In aortic dissection, instead of the whole wall rupturing, blood enters a break in the intima and spreads through that media layer. Predisposing factors include age and hypertension, Marfan syndrome, Ehlers-Danlos, iatrogenic damage, and a pre-existing aortic aneurysm. Most dissections occur in the thoracic aorta and can be classified based on the specific sections of the aorta affected. Clinical manifestations include different blood pressures between arms, syncope, and neurodeficits if the carotids are involved, pulselessness of the lower extremities if it spreads all the way to the iliac arteries. And if the dissection works its way back towards the heart, it can even cause MI, aortic regurg, tamponade, and acute heart failure. What starts as a dissection could also end up as a full-on rupture. On chest x-ray, look for a widened mediastinum. And this is a medical emergency, people, so start decreasing that pressure. And you, what's with the guitar? Get to work, that's an order. This is no time for lollygagging or loitering or dilly-dallying or shenanigans or horseplay or hijinks. If I see even one jink, so help me.